Two. Ladies and gentlemen, may we start our proceedings? Say okay. May we start our proceedings? We will start with a word of prayer. I will ask Margaret Sinding from the lab, since TB has everything to do with the lab, for her. Where's the microphone? To lead us in a word of prayer. I'll give you mine.
May we pray. Babe siyabonga nasekuseni egameni lika Jesu. Sibonga nasesikhathi lo siphe sona. Nanalanga ukuthi sitawukhumbutana ngendzaba yethu ka-TB. Siyathandaza uNkulunkulu wethu lo ngcwele esihole konke lesitakwenda namhle.
Two. Just I think. Two. Women. Two. Oh, now it's on. Welcome. Honorable Minister, members of Parliament, as led by the TB caucus, partners, all our partners in the fight against HIV and AIDS, but today we are talking about TB, which is the cousin to HIV and AIDS and has cost Emaswati so many lives. All protocol observed. Good morning. I want to start with a quote, Honorable Minister. An African quote which says, "You cannot climb a bead of success with your hands tied up." And to support that one, another African quote says, "Those who respect the elderly pave their own road to success." With those quotes, I would like to welcome you all to today's function. We are here to commemorate TB, and so many times people have been asking me, particularly the media, they keep on saying we have forgotten about all the other conditions. We are only talking about COVID. But then, as we all know, COVID touches on all these other conditions. My name is Vusim Makakula from Togolago. And I am the Director of Health Services. I bring in apologies from the Principal Secretary. The two principals, it becomes very difficult to bring together the Minister and the PS. So he had to remain with a lot of other tasks for us to be here. I would like to welcome you all. Everyone is welcomed, even if I have not mentioned you. I cannot mention you all because we are all in here and we are all in this fight. The Honorable Minister had asked us to continue, but I felt, no, let us wait for the Minister. It doesn't matter. We can wait for the Minister even until 12, because we want her to grace us, and we know that she wants to be here with us. But then, as you can see, my IT was still trying to sort out things, so all the same, we couldn't just start. We are going to follow our schedule as it is. we'll try and keep time because there's a lot of things that are happening. We are here to invest to end TB, because when you do that, it saves lives. Our first presenter will be none other than the TB program itself. The TB program, head by Themba Dlamini, will come and give us the strategic plan, which we are currently under guidance of, the 2020 to 2023 strategic plan. The only things I can say about Dlamini is I've known him. And for those who don't know, we are the same age with this guy. And we are going. So this is probably the last function we are doing together with him. But he has been with TV ever since. He actually knows TB. Besides the technical part of things, he knows all what has happened on TB during the times of the former director, Dr. Mabuza and all. He has guided and done everything. When we started seeing the decline in TB, I thought of him. I said, hey, I wonder how Themba feels when he sees this graph coming down now. And yet, at that time when it was up there, it was a mess. Ladies and gentlemen, Ngos, Themba Dlamini, the floor is yours. Oh, thank you. Thank you, Sisi.
Honorable Minister of Health, Mageli Zinkosi, parliamentarians who are here, senior officials, partners of the ministry, ladies and gentlemen, normally on such occasions when there is the minister and members of parliament, I don't talk. So I might not be good in the salutations. I'll quickly hide behind the technical one we use and say, with all protocols observed. Like the director has mentioned, I'm Themba Dlamini, the National TB Program Manager. Today I'm going to be giving you a snapshot of the current Minister of Health TB strategic plan, which started last year, 2020 to 2023. This is going to be the outline of the presentation. I will start with the process of developing a strategic plan, not only for TB, but generally before you develop a strategic plan, you have to do some groundwork. You have to understand the epidemiology. You have to understand where you are. You have to understand the environment you are developing the strategic plan under. You have to have a work plan. You have to cost the strategic plan. And you finally have to print and have a strategic plan. But basically, these are the basic principles of developing a strategic plan. Moving to the strategic plan, of course, the Ministry of Health, through the TB program, has a vision, mission, and goal to combat TB in the country. The vision is a Eswatini-free of TB by 2035. Of course, I know the minister wanted earlier than that, which we promise we will try, or those who will be remaining. And the mission is to ensure the provision of quality care and prevention services for all people in Eswatini with TB disease and TB infection. Our goal is to reduce TB by 25% and TB death by 50% by 2023 relative to the 2018 levels, which those are the incidents we want to have for 441. We want to have, and then have the 95 people per 100,000 deaths. So this, in actual fact, will culminate in reducing the TB incidence by 50, and reducing mortality by 80%. We have 6 strategic objectives for this strategic plan. The first one being to increase case detection. That is, we want to find the TB cases that are out there, even those who are not able to come to the health facilities for many reasons. You know, TB is also a disease for the poor. So some can't come to the hospital because they don't have money. Others have got a very low threshold of going to the hospital. So we are going to try to find these cases from the community, in the facility, any congregate setting, everywhere. We are saying by that, we will then, if the estimates down there, we are going with the estimates, we should be treating 7,706 TB cases. Some of the 25% of those cases coming from the communities. And of course, we want to make sure that we also diagnose children, which is a very difficult group to get. A child cannot just go to hospital. You need somebody to help the child to go to hospital. So we are working with all stakeholders who are dealing with the childhood disease, and we are hoping that if we are going to find all the cases that are there estimated for children, they should be 1,084 by 2023. This is a bicycle that goes to the community. The 25% we're talking about will come from these people who go to the communities, do door to door, and actually carry this specimen to the health facility. And the minister has got very good diagnostic facilities which can diagnose TB within the shortest possible time. The next strategic objective is to increase the treatment success rate for drug-susceptible TB from 89 currently to 90%, and also for drug-resistant TB from 77 in 2019 to 85%. Of course, we want to make sure that the patients we find, we diagnose with our novel diagnostics, are put on treatment, and we want them all successfully treated. We would wish not to have any death. At least, if we can't have 100%, at least 85% of all those cases or all those patients we have found should be treated. We will find them, we will treat them in the health facilities, we will treat them in the communities. We will support them in the communities with our motorbikes and bicycles. That's what we do. TB treatment is a very difficult treatment. It is the longest among most diseases, maybe second to HIV. So it is very difficult, and it has got a lot of side effects. So we want to follow these patients and make sure they take their medications until they are successfully treated. The third strategic objective is to increase coverage of HIV testing among TB patients to 100. We are aware that HIV is the main driver for the TB epidemic. So we cannot combat TB alone. We need to combine, provide a one-stop shop for TB and HIV. You must know your HIV status so that you can check for TB. When you've got TB, you must know your HIV status so that you can take both treatments. We are already at 100%. It is just that in the medical world, usually there is no 100%. We just call ourselves 99 deliberately, but Minister, we are at 100% in providing this kind of service. Strategic number 4 is to increase preventive services uptake among eligible key populations. We want to move. We have talked about TB. People know about it. We have introduced diagnostics which are faster. We have medication. But we are saying, can't we move now to be more robust on prevention, on how not to get TB? So this strategic objective is mainly looking into that, so that those who are vulnerable, who can quickly catch the disease, like children in some vulnerable populations, we give them medicines to prevent the occurrence of TB than to say we will wait, come early to the hospital. We want to say this is how you cannot get TB. Here you can see these vulnerable populations, including children in the health facility, being given preventive TB medicines. Strategic number 5, the minister wants the TB program to have a very strong leadership. Of course, she is the leader. To make sure that we have a strong program that is going to come up with very good interventions, working with the partners on behalf of the ministry. And you can see that we are getting the leadership from the highest level. This is our PS with one of the TB staff, and that's the program manager. It's very rare where you can find a PS interacting with such a junior officer, but this is the kind of support we are getting from the ministry. And also working with partners. Our directors always provide that kind of direction. This is just one example where we were launching a laboratory in the correctional services. We have done the same with the police. We have done the same with the army. So we work with those groups because for us, they are special group because they are a congregate setting and they work under very difficult conditions. One of our partners here, I think it's Dr. Johannes, which can see the public health director, Margaret Joyce, leading by example in the forefront. Now, strategic objective number 6 is to establish and maintain a mechanism for collaboration and accountability across programs, ministries, sectors, to address the determinants and consequences of TB. We know there are so many determinants, social determinants like poverty, mainly is poverty, not eating well, not staying in good houses. All those social determinants need to be addressed. Of course, if they are to be addressed, you have to have our minister leading the pack, and of course, for her to be accountable as well, she chooses to be accountable in Parliament. Hence here, this was the establishment or launching of the TB Parliamentary Caucus, where the minister challenged the MPs, some of them are here, to say, I am accountable, I will always keep you abreast on how TB is working. And on your side again, your accountability is to make sure that TB is also in the agenda in Parliament. This is the director again, Dr. Makakula, also leading, by example, leading the pack. Now these are the key priority interventions which I've already talked about, or I will just brush through. We will find them in the communities, we will find them in the hospitals. Intensified case finding means everyone who goes to the facility, even now, everyone who enters the facility is screened for TB. Whatever problem, even if you are visiting, they will want to screen you for TB. The other one in terms of diagnosis is to expand the technologies for diagnosis. Just last week, the minister, through represented by the Director of Health Services, launched TB sequencing, a very strong diagnostic tool which the minister likes, and it has started to come in through TB, but she has said she would like it to be extended to other programs, sequence HIV, sequence malaria, and all other diseases, so that we can quickly diagnose. Even if the germ is so difficult, this sequencer will make sure that we find these cases, especially the ones that are mutating. So here, the Director of Health Services was unveiling and was actually launching the sequencing with the minister's partners from Germany. And these machines, small as they are, they do wonders. And they came in like this, maybe to ensure that they are new. They have never used somewhere else. So this we are going to enhance by making sure that we enhance a specimen to get into this machine and quickly diagnose the patients whatever kind of TB, no matter how difficult it is, this sequencer will find it as quickly as possible and actually tell us what kind of drugs to treat these patients with. Treatment and care. We also now want to make sure that we support the patients. All the RTB in the Ministry of Health, all the RTB patients are given food packages, all of them, so that we support them whilst they undergo treatment. Most of them, when they've got the RTB, they can't even go to work. They lose their jobs and everything. But thanks to the ministry for thinking innovatively, getting our partners to make sure that these people get the food packages. Food packages enough for the family, if it's a normal family, maybe of 5. We are not saying we are giving this package to the patient, but we are giving this package so that the patient, together with the family, they can also survive. We don't want to find a patient that has been treated well, and then now the other people who are staying with the patient are also developing TB. So you can see that then I mentioned that we are moving into trying to prevent TB by providing preventive therapy so that we prevent TB occurrence than to start working when the patients are already sick. This will also is integrated in the Central Information Management System, whereby even if you see this patient as a medical doctor or some practitioner, you can see that the patient has been treated for TB, so you can start making sure that they are also supported. This, the ministry also move into initial surveillance, also do periodic scientific studies to ascertain what is obtaining on the ground. Is it true to what we see in papers? So this is periodically done through prevalence surveys, which the ministry did one in 2017 and another one in 2018. Those were the facilities that were used, that mobile clinic. And here, I think the picture is not so clear. It is when the Director of Health Services, Dr. Makakula, commissioned this big team to do the prevalence survey. So part of this information, part of the strategic interventions and objectives came from this evidence that was created from these surveys. And we will continue to do these surveys. I think the next one is due in 2025. Now, as I conclude, Honorable Minister and your guests, this strategic plan was developed under very difficult conditions, under the COVID-19, and we knew that it was going to give us problems. Instead of sitting and saying we will see whether COVID goes or not, we made an upfront investment to make sure that with or without COVID, the ministry will continue to provide quality TB services. So we, for example, we combined the messages about TB and HIV. We are making sure that we screen patients for both COVID-19, and we are making sure that patients will be supported at home. Now we are going to have a patient just being supported on a phone and talking to the healthcare worker directly and on real time. So all those things were thought of COVID-19. Should another lockdown come in, we will be able to also see our patients. So I think with that, Minister, we thank you for this blueprint to combat TB in the country. And as you can see, the team, including your implementing partners, have bought into the strategy because we went multi-sector, we went into the communities, we worked with the partners to come up with him. So the Minister of Health, like the Minister usually say, that we'll continue to provide quality services for all diseases, not only TB, but we will continue to fight TB. Come other problems, we'll make sure that we also fight TB. I don't think the ministry is forever indebted to these partners. Maybe they're not all here, but of course, we acknowledge them as a TB program on behalf of the ministry. We are getting a lot of technical and financial support from these partners. Invest in TB, save lives. Thank you.
Thank you. Thank you very much, Baba Dlamini. Like I said, we come from far, Honourable Minister. Once in 2018, during the TB high-level meeting in New York, we were with him, Baba Temba, and you know, when the President of the United States is around, things change. We had to wait out in the rain until we were soaked, thoroughly wet. I felt so bad because I had just bought my laptop. It got wet. We were still trying to get in because of the security measures that were happening. And that, Honourable Minister, had happened because of one organization, MSF, which had sponsored us to go there because we didn't have enough money as a ministry, we couldn't all go. And then we were sponsored by none other than the Médecins Sans Frontières, an organization which, Honourable Minister, I must say, has saved so many lives in the country. They have helped us when we were in serious trouble, running out of certain medication, with the press going all over the place, telling us there's no medicine, when actually there's one crucial medicine that is probably missing. We will go and cry to them. And they have never turned us down. That's why I'm saying so many lives have been saved by this organization. I recall when the organization was coming in, it was as a result of one of the former prime ministers, that was Dr. A.T. Dlamini, who actually went straight to MSF and said, I always see you helping other people, but I've never seen you in my country. And then when the time came, they came to assess to see, is it really necessary for MSF to intervene in the HIV situation we're having? So they came and assessed, we were together with them, and we never knew that they were really going to be helping us save the life. Ladies and gentlemen, help me welcome in stage the head of the MSF mission, Dr. Penat. I always have a difficulty pronouncing the name, Ketchberger, even though I spent some time in Germany.
The Honourable Minister of Health, members of Parliament, directorates, National TB Programme, all stakeholders and protocol observed. Thank you for inviting me to give a speech here today. And yes, my name is Bernhard Kerschberger. I think the pronunciation was very well. Thank you very much. So I will not give a real speech, actually. So I just want to put up some slides in order also to recap what was done in tuberculosis over the many years, the last 10 years. Why? Because during the last 2 years, we had this challenge of COVID-19. I think we have to go back to see where were our successes in TB and re-strategize and see what are the missing gaps after COVID. How should we move forward and what do we have to do? So my presentation will be mainly focusing first on what was done specifically in the Shiselweni region, then what was the impact, just one data slide, not more, and then the conclusions for the way forward. Just to remind us, so Médecins Sans Frontières, also MSF, or Doctors Without Borders, it's an international organization. where we're really providing medical assistance for people affected by conflicts, epidemics, disaster, and so on. MSF is present in 88 countries all over the world, and we provide medical assistance also in the Shiselweni region. And MSF has been in the Shiselweni region since late 2007. Our focus was mainly on HIV and tuberculosis, but recently also on NCDs, so specifically hypertension, diabetes, and COVID-19. So why did MSF actually intervene in the Shiselweni region since 2007? I think when this assessment was done in 2007, it was realized that HIV and TB care was very centralized to 2 health centers and 1 hospital in the Shiselweni region. The Shiselweni region had a very rural population and was very much most disadvantaged in terms of socioeconomic development, but also in terms of health indicators like the number of doctors per patient, midwives per patient, nurses, community healthcare workers. So the aim was really to intervene or to support the ministry in a region which had the biggest challenges at that time. So what were the activities done at that time? First, and I think this was the most important, between 2008 and 2010, it was a decentralization of TB care and HIV care actually into all the primary healthcare clinics. So TB care has been decentralized to more than 23 primary healthcare clinics in all over the Shiselweni region. What does it mean for TB? It was about TB screening, sputum collection for TB diagnosis, TB treatment initiation by nurses. Nurses have been trained to initiate TB treatment and to provide TB care follow-up. But also HIV was integrated into those clinics because we know that many of our patients with tuberculosis, they also have HIV. And of course, let's not forget, not everybody can be treated at primary healthcare level, and patients needed to be referred. So MSF was also strengthening the referral to higher level care. Let's not forget, in order to be successful, there was also the need to invest in capital projects in order to support access to care and also to improve quality of TB care. So what can you see here on this photo, actually? Well, the light is a bit, so you don't see it very well, but I think you can see that this is the TB ward, which was established by MSF at that time in Hlangano Health Center. But before we go there, what was done at decentralized level? In terms of those capital projects, we really tried to improve also TB infection control. This meant the rehabilitation of many primary healthcare clinics in the region, improving overall infection control and ventilation in those facilities, but also waste management, because we know TB is an infectious disease. So also waste management of infectious disease was one of the priorities. Another important capital project was to provide also inpatient care for TB patients. So in 2011, MSF established a 30-bed drug-resistant inpatient facility in Hlangano Health Center. And here on the photo, you can see how it was built at that time, and then how it looked like after completion. Notably, this TB ward in Hlangano Health Center, it was coming with improved ventilation for infection control. And recently, since COVID-19 also hit the country, it also became actually the national TB referral ward for the country, after Moneni being repurposed now to become an NCD center. The total cost at that time for the construction was around 7 million emalangeni. Another important capital project, and it was mentioned before, it's about TB diagnosis. So MSF actually established a Biosafety 3 TB laboratory also at Hlangano Health Center, and also introduced new diagnostic approaches at that time. What were those diagnostic approaches at that time done in the TB laboratory there? It was fluorescence microscopy, gene expert testing was introduced, but also culture-based methods. And here you can see the TB laboratory from outside and also from inside, how it looks like. Another important capital project, and this is just happening now actually in the Shiselweni region, not only focused on TB, but also on COVID-19. It's the construction of two oxygen plants in Shiselweni, one to be constructed in Hlangano Health Center and the one in Hlatikulu Hospital. Here you can see how the construction is ongoing, and we hope that it can be commissioned towards the end of April or sometime in May. The total costs of these capital projects is around 12 million MLangeni. And why? First, to improve COVID care, but let's not forget, also our DP patients need oxygen. So it's also a mid-term and long-term investment to improve DP care in the Shiselweni region. I already mentioned before we invested in capital projects to improve DP diagnosis, but DP diagnosis is not only happening inside fancy laboratories. Let's not forget, the introduction of gene expert testing in the Shiselweni region was also very key in order to decentralize DP diagnosis more to the primary healthcare clinics. And more recently, the introduction of DP lump testing in primary care clinics, where actually the patient just needs to provide a urine sample and can be tested for tuberculosis infection. But let's not forget, TB is also a very, very long disease. You'd have to take treatment for long. This also means that we have to think about patient-centered care approaches for improved treatment outcomes. So as MSF, we were providing a holistic patient support, specifically with focus on DRTB, drug-resistant TB patients. What does it mean? We were providing patients treatment preparations, adherence counseling, psychological support. If there was a need, there was door-to-door medication refills, specifically during the COVID-19 pandemic. Food support, as already mentioned before, is one of the key interventions to support patients in a holistic manner. But also engaging the community for patient support, neighbors, friends, to provide support to the DRTB patients inside the community. But of course, let's not forget, some of those patients also need more support. So we also organize referrals outside of the Shiselweni region for further medical assessment and treatment. One of the new things which was introduced during the COVID-19 pandemic was the video-observed therapy. Previously, patients had to come to the healthcare facility normally for DOT, for direct observed therapy. But with video-observed therapy, this DOT can be done actually from the patient homes. So the patient gets a mobile phone with an application installed, can take the treatment at home, and making a video of treatment taking, which is sent to the healthcare worker. The healthcare worker can review the video and can also contact the patient if the healthcare worker sees there might be a problem with treatment taking, and provides direct and immediate support if there's a need. When we talk about patient-centered approach, we also have to think about how can we make the treatment taking easier for our clients. On the TB treatment part, for instance, there was the introduction of new medications into the country some years ago, or more recently, the introduction of the oral short course DRTB treatment regimen. Instead of giving injections, like in the old times, now the treatment relies completely on oral medication. It's using newer and more effective medications. The duration is shorter, around 9 to 12 months, and it has less side effects. And we also know it's preferred by our clients. On the prevention part, we also introduced a fixed-dose combination for TB preventive therapy, where different medications are put into one tablet, so the patient doesn't have to take many different tablets, but can take one tablet for TB preventive therapy. This one has been also introduced some years ago. However, we also know that tuberculosis comes with a lot of stigma and discrimination. So we also were investing a lot into fighting against discrimination at community level. There's different ways how it can be done. One way was to integrate TB into all community activities. So TB education, TB screening and treatment was integrated into all HIV community activities, as well as COVID activities at the moment. We were also training traditional healers, rural health motivators, and other lay cadres inside the community so that they can recognize symptoms of TB and initiate referrals, but also talk in the community about tuberculosis in order to reduce stigma. Another important matter is to really more proactively involve the community in DRTB care, specifically patients who take the treatment at home for a multi-drug resistant tuberculosis for many, many months. For those patients, in order to be supported, we were training actually family members or treatment supporters, which can be like a neighbor or a friend, in order to support the patients in terms of psychological support, but also to provide direct observed therapy in the patients' homes. Those community members have also very often become actually the TB ambassadors inside their communities to talk about TB and to reduce stigma. More recently, we also try to integrate tuberculosis into COVID-19 care. And that's very important. On the one hand, to reduce stigma for COVID patients, because COVID patients can also be affected by TB. But we also know that TB patients have a higher risk of death if they get COVID. So we integrated screening and testing for TB in all patients who are also COVID-19 positive. Patients who have TB were also screened for COVID-19, and all patients with COVID-19 and TB were treated for both diseases. Treating not only one disease, but combining the treatment of many diseases is also one way, actually, how we can fight stigma against TB, but at the same time to provide better patient outcomes. One of the most recent developments is also to invest into digital health promotion and information sharing. So we have also established Facebook websites or on Twitter or even on WhatsApp, where we try to provide, on the one hand, information about tuberculosis. So this is not only for the rural populations, but can also be for the young people who may be very much affected by tuberculosis. This is one new way that I think we can reach out to our clients to prevent TB, to support TB treatment, but then at the same time to fight stigma against tuberculosis. So, after this many, many years, since 2007, what is the impact? What are the lessons learned? And it's just 2 slides, one data slide and 1 slide on the conclusions. So I think the impact is quite interesting. And we can see on the right side, how the number of new TB infections, TB notifications has decreased since 2009 until 2016, and it's still continuing to decrease. And I think this was one of the big success stories here in Swaziland, that not only HIV infection decreased, but also very much tuberculosis. And I must say the decline in tuberculosis was even much more pronounced, actually, when compared to HIV. And TB decreased. And TB decreased in all the populations. In patients who were HIV negative and had TB, TB was decreasing. But most pronounced, it was also decreasing among people who were co-infected with HIV infection. And I think this is important to remember, one of these big successes, I think, during the last 10 to 15 years. When we look at the number of TB-related deaths reported from the Shiselweni region, and you can see it on the left graph, you can also see that the absolute number of TB-related deaths has been decreasing dramatically from 2010 onwards to 2017. So there's big successes. But of course, we should not forget we had a lot of challenges during the last 2 years with COVID-19. So we also have to remember ourselves that the success may not be sustained if focus on tuberculosis is lost. I think we lost some focus on TB during the last 2 years, so maybe we have to refocus on tuberculosis again. So what is needed? As I said, let's refocus on TB again, despite COVID-19. Let's also sustain external funding, I think, which is important. And I think there's some commitment from MSF to continue to provide some funding into tuberculosis care here in Eswatini. But let's also not forget about domestic funding. And here I would like to reach out to the Minister of Health, members of Parliament, to the government, Ministry of Health, that we also have to increase domestic funding in the next years, I think, in order to be successful with TB care, TB prevention. What does it mean? We have to invest in screening and testing. I think more screening and testing needs to be done after these 2 years of COVID-19, where there was some neglect on screening and testing for tuberculosis. We have to invest more in medications, to have new medications in the country, to have sustained medication supply for everybody who needs TB medication. And let's also not forget about human resources for health. I think this is key, especially knowing that TB will stay with us. We have to capacitate our human resources for health, to continue capacitation, and to invest, and even to bring more human resources for health, specifically also for tuberculosis. And thank you very much for your attention. Thank you.
Thank you very much. May we give him another round of applause? Honorable Minister, I decided not to preempt the things he had done. That's why I was small in saying what MSF had done for us. As we move on, I would like to actually quote my third quote from one of the people I respect, President Samora Machel of Mozambique. He once said, "The rich man's dog gets more in the way of vaccination, medicine, and medical care than do the workers upon who the rich man's wealth is built." Ladies and gentlemen, at this point in time, I would like to request Dr. Lukele, Begumusa Lukele, from Baylor, to come and give us his remarks. As he comes up, I would like to note and honor a former PS who made Baylor possible. That was Dr. John Kunene. Can we give him a round of applause in his absence? He worked hard. At that time when it was still theory, we just thought, it's one of those talks. But Baylor College is there, now in Mbabane, and saving children. Dr. Lukele.
Honorable Minister of Health, honorable MPs present here, the Principal Secretary in the Ministry of Health in absentia, Acting UN Resident Coordinator, His Excellency US Ambassador, Representative, MOH Directorate, CDC Director, Business Eswatini Representative, all government representatives, country directors of the Ministry of Health's implementing partners, I greet you all. As Baylor Eswatini, it is our pleasure to join this 2022 World TB Commemoration Day. We are particularly pleased to join the whole world in joining hands, celebrating and commemorating this day. This World TB Day comes at a pivotal time for the children impacted by TB. We see a lot of exciting progress, and as usual, we also see concerns, as it usually is with children. Most of the time, we see children lagging behind or coming behind in healthcare and other services. And globally, for the first time, we also see increase in TB-related mortality. In the same breath, we also see incredible reason for optimism and hope. First, as you saw the presentation of the country strategic plan, we're excited that children in Eswatini are not left behind. They feature very prominently in the strategic plan and in the efforts to end TB by 2035. Also, we are excited and interested in seeing that World Health Organization has released a consolidated guideline and operational handbook for children with TB. We at Baylor Eswatini and Baylor College of Medicine are blessed and pleased to have contributed in this work through systematic reviews of GeneXpect Ultra performance from multiple specimen types and the development of operational handbook chapters in the World Health Organization's guidelines. These new guidelines and the handbook have a potential to greatly improve TB care for children, adolescents in several ways. One, support for the use of non-invasive specimens such as stool for diagnosis of TB in children. Two, new evidence-based clinical diagnosis algorithms for diagnosing clinical TB in children. And three, shorter, up to 4-month treatment options and 6 months treatment options for children with non-severe TB and TB meningitis, respectively. The use of the new TB drugs, such as bedaquiline, for children of all ages without restrictions by age and weight. The fifth one is support for family-centered and community-based models for care for children management globally. These new recommendations have the potential to greatly improve the lives of children, but only and only if robustly implemented. We look forward to continuing our close relationship with the Ministry of Health, partners to support implementation and integration of new guidelines to rapidly give children access to these new recommendations. We will also continue to generate new evidence that impact diagnosis and the care for children in Eswatini. Some of our recent and ongoing generating evidence projects include systematic reviews of expert and non-invasive specimens, evaluation of community-based family-centered TB prevention programs, assessment of novel stool and blood-based diagnosis for children with TB, evaluating of the impact of helminth infection on BCG responsiveness, and also the assessment of new screening strategies for TB DSD models for prevention of TB in children, and also supporting the introduction of TB sequencing to identify TB drug resistance. We are also implementing evidence in generating host genomic factors associated with prognosis of TB. We know through working together on adopting proven guidelines and investing new approaches with the Ministry of Health and partners, we can reach our goal of eliminating TB in 2035. Ladies and gentlemen, please allow me to congratulate and encourage and recognize all health workers behind the scenes who work tirelessly every day to make sure that children with TB are recognized and treated effectively. I would like to wish you a great year ahead as we continue to hold hands and fight TB together. I thank you.
For all the things that you've done for me.
Thank you very much. Now that Honorable Minister has been updated on our children and TB, we need to get a global picture of how TB is, how this dreadful TB is. It has claimed so many lives, but we need to know how we are doing. One question, Honorable Minister, as I often do my job, what I normally get from the press, whenever we're talking about something, they always want to know how is Swaziland doing in whatever it is that we talk about. So we'll be comparing ourselves. Ladies and gentlemen, another Lukele, Dr. Nomthandazo Lukele, who represents WHO, will come and give us the global situation of how TB is. Before we get our break, immediately after that. Dr. Lukele, the floor is yours.
Thank you, Director. Honorable Minister, Senator Lizzie Nkosi, members of Parliament present here, US Ambassador, Senior Minister of Health officials, the UN family present here, and all partners, the civil society groups represented here, all protocols observed. Good morning. I am really happy to be given the opportunity to give a presentation on the global situation on World TB Day. I think I need support so that my slides start showing from slide 1. Thank you. It has to start from the beginning. So while IT is setting up, the World TB Day is really a day for us to look back on where we started with TB and recommit to the new targets. It has to go to slide 1. Sorry about that. Thank you. Thank you. So it's really a day to look back on where we started, where we are, and where we want to be. So before I continue with my presentation, I would like to know that when you think of the disease TB, what comes to mind? Just think about it. Ish. Okay, but now it has to be in slideshow. Then how? Okay, I hope I'll master this. Forgive us for that. So I was asking what comes to mind when you think of the disease TB. So as I was putting up the slide and I was looking at when TB started, the bacteria was discovered in 1882. So TB is over 100 years old. It's a disease that infects the lung, and those that have the disease will cough and continue to transmit. It is a disease that affects families in communities, the elderly, the middle-aged, the adolescents, and children. And often these are people from poor communities where there is often overcrowding. And while TB is a preventable disease, a curable disease, it is one of the leading infectious disease. Actually, it's been the leading infectious disease globally up until COVID came. So now it is number 2. So it does lead to death. And then COVID came, like I'm saying. I don't know, was it a blessing or a curse for COVID to come? But here we are in this area, in this era. So this is the outline for my presentation. Mainly the purpose of my presentation is really to get all of us reignited, recommitted to ending TB in Eswatini. What we have seen in the COVID era is that in 2020, for the first time in decades, the TB deaths increased. And then in 2020, which is still in the COVID era, fewer people were diagnosed with TB. So you can see that sharp drop from 7.1 in 2019 reported cases to 5.8 million. So fewer people were reported or diagnosed with TB. On top of that, fewer were treated or put on preventive therapy for TB. On top of that, there were fewer resources that were channeled for TB, for the TB response. As you know, we do globally have the NTB strategy, which is there, the WHO NTB strategy, which is there to help countries to get to eliminate TB as a public health threat. In that TB strategy, we are aiming for a world free of TB. And what do we mean by a world free of TB? It is going to be expressed in terms of 0 deaths and in terms of 0 families suffering from TB as a whole. So where we are, you will appreciate from my slide that we are really lagging behind. When you look at the target that was set for 2020, we should have reduced the TB incidence by 20%. But at the end of 2020, globally, we had reduced it by 11%. Coming to TB deaths, between 2015 and 2020, they should have been reduced by 35% from that baseline, but we had only reduced TB deaths by 9.2. When it comes to catastrophic costs, what are catastrophic costs? We are saying in an income of a family, they shouldn't be spending more than 20% of their income on TB care. So what we are noticing globally is that we are still at 47% in terms of families suffering. Again, we have the UN high-level commitments, which we are supposed to report to as a country by end of 2022. There's a target for TB treatment. By end of 22, globally, we should have 40 million people put on treatment, but we are still at 19.8. So similarly with TB prevention therapy, 8.7 million, yet we said 30 million people should be there. So you can see that globally, things are not looking good for TB. We are lagging behind. Even when it comes to funding, there is a gap. Like the plan was to have 13 billion annually given to TB, but we are only getting 5.3 billion to respond to TB. And also for TB research, it was supposed to be 2 billion annually, but we are getting like millions, not even close to, not even a billion to get there. And the situation, so you are seeing the targets lagging behind, the budget lagging behind. Eswatini is also not left behind. When you look at the Global 2021 report produced by WHO, you can see the funding landscape, how it's progressing over the years. From 2017 to 2021, the blue represents the domestic funding, the orange or brown, or it's appearing yellow there, is representing the international funding, and also the red. For the first time in 2021, we are seeing that there are TB program activities that are not funded. So clearly this is the landscape we are in, and we seem to be following the global trends even with our local data. So when you look at the TB incidence, in 2020, it is reported that there were 319 cases per 100,000 for TB incidents. And we are moving towards a TB incidence. Let's say for 2020, we wanted to pay 264 per 100,000 people with TB, and we want to pay 164 per 100,000 according to the strategy that the program manager was reporting. So clearly we are behind the 2020 target, and it's up to us to see how we regroup to get to the 2023 target. Similarly, with TB treatment success, in 2019, we're sitting at 69%. So meaning out of those people we know have TB, how many did we manage to find and put on treatment? So we were at 69% in 2019, but according to the 2021 report, for 2020, we're sitting at 58%. And we were aiming to be at 90% by 2023 because we want universal coverage, health for all. So clearly you can see that treatment coverage is also lagging behind. If I were to compare this data with global data, the TB incidence in the African region is it's 222 per 100,000. So we have slightly more cases. The TB treatment coverage is at 56% in the region. So we are just above the average there. And then the case fatality rate for the country, for 2020, we're sitting at 25%. This is quite high. The region is sitting at 22%. And then we don't have data on catastrophic costs. And it is in the national plan that we want to do this survey to see how much of suffering is TB causing to our population. So really this is where we are. And really, what will it take for us to end a disease that is over 100 years old? I'm looking at COVID. COVID, this is just a disease that came in 2019, and already there is hope. Already there is hope. It's not like when it started. But with TB, I don't know. Maybe there is hope, but we still need to do more. I'm looking at HIV. We've already achieved the 95 global targets, even ahead of time. But what will it take for us to end TB? So what are the lessons that we have learned from responding to COVID or from responding to HIV that we can adopt as a country? If I were to go through, with the COVID response, we saw global and national commitment. We saw a multi-sector response, even displaced in country. We saw funding coming in to respond, money coming in internally and externally. There's a lot of research, even as we speak now, vaccines are coming in, new evidence on treatment that is coming in. I think one thing that came with COVID was the speed. Things that at a pace we were regrouping, meeting, and just taking whatever global recommendations were coming in. And then it was also patient-centered approach, services getting to the people, RRT in the communities, testing decentralized. These are some of the things. Data, situational reports given every day, we were responding to it. The same thing is needed for TB. You will notice that a lot of money was pumped into getting us where we are. And these are the same lessons and the same approaches that we are recommending for the response to TB if we really want to get to a state where we will see a world free of TB. So as a country, WHO recommend that we regain momentum to end TB by 2030. We need to fight TB and COVID-19, HIV, and other diseases simultaneously. We recommend that we implement WHO frameworks, guidelines, and recommendations. When it comes to TB, there are tools that guide the multi-sector collaboration. There are tools that guide the continuity of essential medicines. And Dr. Peggy has just said that this week, WHO launched the guidelines for management of TB in children. So as I close, this is really a call for all of us to invest in TB and save lives. Thank you. We had a short video that we wanted to show, showcases how Swaziland has adopted some of the recommendations. I must say that the country is being recommended for being one of the early adopters of the WHO recommendations. In 2018, WHO recommended that a short dose regimen be given to MDR patients, TB patients, instead of the injectables. And also, WHO is calling for innovations in the context of COVID. So we are happy that Eswatini has adopted this. So this is just a video to showcase how it has translated to patient care. Thank you. Okay. I think we'll play it later because there's issue with volume. Yeah.
Thank you very much from WHO. And the most notable words she said is, we want a world free of TB. Koko and Sloan. We need a bit of a break and have an edutainment.
One, two.
Wo silwane mani lapha. Nani msuqalatha manje nje. Ubuya kuphi?
Hawu gogo. Sengibuyile.
Awukeva lo mbuto. Kulula ke silwane kulula ngoba vele kuva kusitona indoda yakho. Silwane sekunemthetho lomsha la ekhaya. Ungaphuma na ubuya, ungangeni. Ngiyakuscreena. So ulungele kambi.
Ngilungele gogo ngifuna ukungena manje Nkosi yami.
Mani ulungele kambi.
Ngilungele.
Uyakhwehlela.
Angikhwehleli.
Loku nawulele uyafoma lokungathi uyajuluka nje.
Kuya ngithi ngibethe iphi ingubo gogo lento leyo.
Utawujika esilwane.
Oh angifomi.
Kuyendeka uvo ngathi uyashisa nyalo nawuthi uyashisa finze ngathi uyabanza ungathi ulunywe imbuzilwane nje ukuhlanganyele ngethi ikhawu
akwendeki lento leyo gogo.
Kuthimula
Angithimuli.
but sithi ayinweni lesifonyo silwane ngoba ukuconza kwalesifonyo ukuthi ngathi bowuthimula wena.
Gogo akwendeki tonke lethi info leto.
So uphasile ke you can come through.
Bomse Yabona gogo into ngiyithanza lo ngendawo nambamba ngiyithanza impamba.
Okay silwane lokho ngiyakubona kungumthetho lomshalenta uthanza ungathanza into yakwemukela la.
But akusenenza lokho sengibuyile.
Ubuyaphi?
Kulo mfundza sikolo phela gogo.
Awusilwane wena njengemfundza sikolo.
Ha, lapha bekubukwa mina ema-answer onke bebawathola.
Hayi phela silwane ngiyakwati mina wena. Ufundzeni?
Umehluko emkhathini wa epidemic na pandemic.
Ngitheni ke lokuthi ukuthi into langakayo ungaofunza into lefanako ngoba yinye lento le kuyafana. Pandemic isilwane na epidemic uva nje lo mic lokuthi yinye lento.
Gogo. Nemehluko lalela mina. Lo mehluko ukhona.
Awukho silwane umehluko.
Phela vani mina lengifundisile.
Uyafana lento.
Akufani lento.
Manje sibute naba labatiko. Kuyafana ngisho. Lokubinza kusho kuvuma.
Kahle gogo. Lalela mina. I-epidemic is a disease that affects a large number of people within a community or a region.
Ayiwasho lapha.
But a pandemic is an epidemic.
Yeah, nako. Sewufuna ngichaze kona lokho.
Phela kugcini lapho kuyaqhubeka.
Uthe yini lokuqala lokwesibili awusafaki leli bizo loshekuqala njalo.
Gogo lokuthi ngithi i-pandemic is an epidemic kuyachubeka.
Ngilalela.
A pandemic ke gogo is an epidemic that spreads.
Silwane. Yini le
Angichubeke phela gogo ngithi sengafika bo multiple countries, bo continents sengiyavinjwa nje.
ngiva le ndlela lolibita ngayo leli bito lo cha uvile.
Thank you.
Bekumedima kuphi esilwane lokusuwente kanje esikolweni ulalele kanje.
Gogo ngumbuto longangibuta wona
Yini leli kukhuni isilwane ngoba phela mina esikolweni ngiyakwati wena ukuthi wawuthola imamaka akho lamahle lapha kubo 12%. Ngize ngikubuta nje ukuthi esilwane emdzaleni ufuna kuba yini?
Ngangisho kahle gogo ukuthi I want to be a doctor ngangisho lokho.
La mamaka akho athi kimi cha. Silwane la kunabodokotela la.
Ngibabonile bonza ngayethu yes ngibabonile. Yes. Ngibabonile.
Silwane kunabodokotela la hayi ukuthi ngemagama abo ukuthi bethiwa abatali tiqu la tiqu ukuthi timphendvulo esikolweni sasitimisela
Yagogo yathi ukuthi dokotela phela uzube ngidokotela ngile misebenzi yakwathi lo masongidokotela suke sebakuphule imisebenzi bodokotela bacaba babonesi bajova abantu le ndlela bajova ngayo kwathiwa saliyekela kujova unesithozi wena suku hamba yoba ngidokotela kajovani gogo
dokotela la balana nje silwane shothi kaze bakumisa kujova abantu
bakufisa kabuhlungu kabi
siyanililela abantu abami Nkosi yami nama ngisumthu longathi ngevana nenyalithi ngangiyanika kusijovani mina
gogo lokunyela ngifundzile lena indzaba ye-TB gogo tuberculosis akusiyo ukuthi tuberculosis gogo tuberculosis anti yabona na TUBE ngitube loyo bese kuba na R says tuber then tuberculosis yabona sidokotela ukhona kahle hle nedi wasuke wacinzetelwa nathi ngolo ingangididle kuseni ngingathole ama Weet-Bix lakhaya
silwane ingolo yekuseni nabo othi akuhlanga nje emphendulweni esikolweni
sorry
chubeka ukuthi ufundzeni lenye
kuthiwa ke gogo njengoba mhla 24 March sigubha ke lisuku le-TB gogo
vele phela silwane lokho siyakwadi
kuthiwe ke sonke gogo asibambisane esitubulweni sinye lesithi invest to end TB
ngiphume lapho ke mina silwane kunala invest bayangathi naba abantwana bofakaza nginalutho timbasha nje abantu abamadiko lo invest to utomle mina la kulesicubulo
gogo
anginalutho abantu abamloko angikubeke nje kusebaleni timbasha ngisulohlobile kahle nami angimfuni TB kodwa la invest angikho
gogo lalela ngesiswati sho ukuthi dinikele ngalokuphelele
ngiyavuma lapho silwane
so invest phela lo
silwane investing yamasha usho kufaka timbasha tibeti nengi timbasha silwane invest
yabona la gogo kunema donors
nabo ke bantu lekhulunywa nabo nga-invest
kunema partners
kuthiwa kulabo bantu silulu semali singene
business community sekuba nathi nawe sonke we must invest gogo hayi ngakhulunywa ngemali gogo wena nje gogo lekhaya nana business lapha ekhaya letinkukhu kunabantu bacashile lapho lokuthi ubavumele gogo ba access ema TB services you are investing
so uveta ke lemfihlo lale bengakayisho cha vele nginetisebenzi lapha etinkukhwini ngingumlumbi
yes gogo
nala kubosilwane ngoba phela ngithi bosilwane ngibaqashile nabo ngawusibala
no ungayoni ke
phela silwane ngimi umnikati waleli business
but ungalapha ekhaya mina fanele ngiyi-co-founder yale business ngingakho nje ngikunika lokuthi letisebenzi divumele di-access TB services that's investing to save lives
kubalulekile ke lokho silwane hayi lokho ukuthi nangabe uneli business so uyangkwabala letisebenzi ukuthi uthi esibhedlela uyatsasalata
gogo umvu wakho ehlela nje lapha engapaneni
mina nje umuntu wathi esibhedlela kuthi uhishiwe uyawutshela dokotela hayi mina
kunjalo gogo
sengingava ngaba ukuthi uhishiwe unginesini wena
gogo ke leboya ushaya yona gogo sina gogo nje ekhaya sibantwana kuwe invest ngekuthi uprotected sina from TB that's investment gogo
silwane indlela yoku-investa lakhaya ukuthi ngibe nikhuthatha njalo ukuthi emafastelo silwane nanihledlini nibe wavula
gogo ku-investa ke indvo lenjalo gogo lokutinikela ngalokuphelele gogo wami ngoba gogo yabo i-HIV is manageable but TB is curable
nako lele ngikuthandako Silwane.
Curable.
Bantu nababambisene badosisana.
Ngekuthi ke phaka Google curable bathi babasifundisa bathi curable ngekuthi unathi medication as advised by the health practitioners.
Bengithi ngiyawuthola kanjani?
Ngebathaya gogo umona ngiyawathi ngebathaya. Umona ngiyawathi ngifundisiwe ngawo.
Lo kwenda ke Silwane ukuthi ungashiyi indzawo le medication ibebete la uyikhawula khona babalekela lokho ukuthi nakwendeke leligciwane laba khona la waqala treatment.
Gogo.
Wayekela nasu ubuye bese liyagwama Silwane.
Yabona ke.
Sibalekela ke lokho.
Kufaka gogo nokuthi uthole ukuthi siyalwa. Ngakushanga emphama. Kufanele ngisalo ngichubeka. Ngoba mangaya le ngithi ngiyabe ngakhange sosifasile ngala wena. So kufanele ngimeke sure ukuthi ngize ngibeka phansi go akungisho wena gogo ngibekisa kulesimo lesisho.
Bese ngibuka Silwane ngofela emaphoyisa khona la. Kanti singaphandle kwala lana bangani bakho inombolo yawo nginayo ngashaya nje ngithi ncesi yemanje singaba nalo litiya. Indzaba yakho nasiyicoce etiyeni ke. Utawubona.
Gogo. Ngicela uinvest ke.
Silwane hayi mina ngedwa. Uyeva mntanami.
Sokhomba ke bani bethi imali ke manje gogo.
Phela vele Silwane nabo bantu bekinvesta.
Uthi kimi ke masingene uyangicela uthi ucela ukukhuluma namkhathi ngithi nje kuwe ngisabitwa na isuthu. Ngiyakuye ngithi mina ngithi
Uthi wena hey gogo manje ngibitwa na umuntu nangeloti imali ngithi lapha Silwane ungadidwa kutsheka kwesifonyo imali inenge.
Mangifika kuye ke gogo ngithi mina kuye le mina ngithi angiwathengisa amasuthu sengakhoza ungathi kunele business lemasuthu. Ngithi sengavala uthi no Silwane. Uphi gogo ngithi gogo uthe lapha osilalela. Ngifuna ukuthi kunalenye idona lathi ukhulume nayo angathi noma sesirosime lapha okay yes uyangavuma uthi kunedona lengikhulume nayo ngithi aseyilungisa imali nginike nihambe nofundisa abantu nge-TB edikolweni
Mshayele ntandla
manje siyabonga mina Nkosi yami we can't wait to start yes nguye nje gogo lona yes
vele mani Nkosi yami usulekile nale socha siyafanana ke thina nawe uyabona
cha gogo hayi insocial invole kwento ufanane naye nje ngipendi kuphela gogo nishubile impela nishubile
abantu bemona ke ngiyabathi Silwane lo muntu
mara ugcoke kahle mani gogo
wondlekile uswekile
nangathi asukume bafundisi angasukuma kucala
hayi Silwane ungadlali ke ngabafundisi
phela bangabese bamhlalisa bathi asisho wena
Silwane ngeke nje kubafundisa azalunga
bamagagulu sibonga kakhulu ngubonene so nanga umthombeni yes so ke
hawu Thombeni uNkulunkulu wami manje ngiyabonga kunini ngikufuna babe magagulu
nanga umthombeni la
hey Silwane
phela ngithi nje ngikutshengise awumboni wena nanga umthombeni
awugutshwa ngaze ngelapheka kokubona mntanami ngididwa kuleti buko sowacatha lethi nje wena ngikwathi ufaka lethi nelithundi phela
nange gogo umthombeni
Thombeni ngimi shemo uyangibona usathi khumbula ethembiso takho kimi Thombeni kaphela ngifuna bese sekungathi kunjani njani ngifuna labantu batshele ngokuthi wangithembisani unginike
gogo ngokhuluma emanga washo wena wathi esikolweni awuthandzana nemva kamagagula wathembisa ukushada ngabe Thombeni nisemileni kuloko noma masombuka nyalo uyayintshintsha ingcotho
manje Silwane ngiqale ngithi market ngifaka iBrazilian
ungayengeke akhona Brazilian lana Thombeni lena nje angathi noma imathaphaniyeni noma yini itihluthekele nje
bantu bemona Thombeni ungaye ngabo ungahawu sweetheart nawe uyahleka uhleka lento ayishiwo kulomntana lo
hawu na minister ukhona hawu Nkosi yami hawu na minister ukhona Nkosi yami make siyabonga vele bengikufuna minister man ngibathi ngiyashaya usabahamba minister uyakupheka ungikhatha hey minister ngisathi boso ngikhathela yini but ungaphendvuli minister ngimi lo shanga ngecontract minister sengantshintshi inombolo
minister ngithangivete lo wabo please call ngilo lo yathumela nje bo please call ngathi baningi ngulo
hawu minister ngimi lo contract hawu hawu baba Sibanze hawu umhlonishwa konje mdlanyo vele bengikufuna mhlonishwa bengikufuna ngingalahlekela imbuti mani la hey ngathi ifuna imbuti yami nguye phela nguye umhlonishwa sengize ngicina
Sibanze angeke akuhloniphe kangaka kani ngulo lo ngimosile
sihambe zakashewula solo sifuna imbuti asithothe sesiyenyangeni ke nayifika inyanga lapha masingena ithi into angenza bayithi imbuti
ngithi mina nayi inyanga sibili Silwane
iyacatheka gogo mina ngigcine ngalile
vele asivumanga mntanami lalela nto okuchazela sasinasingena yathatha sikhwama semathambo uyathi
kwavela wena mhlonishwa uvela ke mhlonishwa kule Times
lathela
Lathela
kiyo
kuyo la mathambo
lamathambo
kwakunesithombe sapho la ubhala ukuthi
ngithi
MP.
mina hawu
Sajabula ukuthi umhlolisho wethu uyavela kaShewula.
kashewula
Sajabula kakhulu. Nkosi yami sibonga kakhulu hawu gogo nangu phela umfulu omdala lana
uyabuka bantu
Doctors Without Borders. Doctors Without Borders.
ngilo silwane babe doctors without borders
Gogo ungajaka kushiwo njalo Nkosi yami cashback phela. Cashback. Shana mvamzana cashback.
cashback
Yes, ngibo labanemali because uthi uyayifaka nje. 12 million, banemali kakhulu gogo. Nanyalo ngathola ukuthi nje sasimela uve bam 2 million. Uyabona, umangalo ukuthi kwethe kanti. Dokotela Baylor. Hey futhi wenza bayakho. Uyakhumbula. Nange lo dokotela lo kathi sekule forum la kusitho khetha lo nto ubuka iBaylor. Ngakuvotela lapho. Ngakuvotela lapho. Bangafuni.
emaphepha akhe nje silwane
Hey bangafuni.
abe mahle kuphela bazonda libhande leti alifakile nakaletha lamaphepha sengibaba seningaye ngaleli bhande utalinjinja yini ke naye ufaka iguchi nami
Mayisiyabonga kakhulu. Thank you so much.
Oh, thank you very much for the break, which allows us to come back and concentrate once more as Stubega. Oh, as of Gucci. Oh. Siyabonga kakhulu for that necessary break, which we've just seen. Our next round is now going to be, we are going to have a talk from the Business Eswatini CEO as represented. Our theme is to invest to end TB, because that actually saves lives. And we know that, Honorable Minister, that investment in Africa's health systems is key to inclusive and sustainable growth. A strong economic growth in recent years has helped reduce poverty by up to 43% in Africa. As we sentiment on the universal health coverage, Honourable Minister, it will not happen without investment. Ladies and gentlemen, help me as we invite the Business Eswatini CEO to tell us more about how business will not function if people are all sick with TB, for an example.
Ngiyabonga director long program director wanamuhla futhi cela ngekubingelela indvuna eTempilo Senator Zinkosi ngibingelele umhlonisho wami wakaManzini North babe Markford nelikomiti lakhe leTB caucus eParliament. May I also greet all the partners present here, senior government officials, people working at grassroots with TB, and people living or that have survived the disease. All protocol observed. Sanbona Nexeni. For today alone, Minister, I am Inathi Dlamini, just for the next 10 minutes. I have been asked to stand in, he asked me to stand in on his behalf because other duties were calling him to be away. And then because we work hand in hand, it became easy for me to step in. But I know ke director gokuthi ngeke nginihlekise njenganathi. because bekatanishiya nitshelele okunengi. But in my starting point, I just want to appreciate the partnerships that we've enjoyed as business around the area of TB. Not only TB, but let me just say health, but today was specific on TB. For many, many years, from the ministry, from the department, from the partners of the ministry, MSF, ICAP, URC, you name them, we've received support over a long period of time. This support saw us getting training of our medical personnel. And even sometimes when there are new protocols or guidelines, they would come down and even assist us training the actual employees or the focal persons that we use as business in making sure that healthcare continues. And we've had access, Minister, to drugs and supplies. So we want to appreciate that support, because through that support as a private sector, we have saved lives and we have saved livelihoods. Ending TB is good for business, because TB endangers livelihoods of communities, and it further reduces the income and market size. So for us, it is an issue. Global estimates suggest that TB, in 2020, TB was costing 12 billion annually to business or to the economy. This was due to absenteeism, presenteeism, as people were battling either to address the TB or were denying that there's TB, they need treatment. And in the process, we lost out on the work hours of those people. Business, therefore, is well positioned to address TB in the workplace. And Minister, may I borrow some words from Adrian Thomas, who is the Vice President of Johnson & Johnson, when they launched a business investment on TB. He said, we need new and bold creative steps. New and bold creative steps are required across sectors in order to disrupt the trajectory of the disease. This says to us, as Eswatini, we've had to do something with TB. We were not asked to do something. It was calling for us to do something. And I'm happy nje when I see lapha etafuleni lakho, Minister, kunemlingano wami lapha, where we pushed for many years the workplace wellness programs. He was looking at the public sector, and I was looking at the private sector, and we shared a lot of information and support to make sure business can continue to happen. Ending TB, sawubona Pungwai. Ending TB is a cross-sector, cross-industry effort. Hence, in 2022, we have launched a partnership to implement business wellness programs with the under-deserving employees, the employees that won't be able to go to hospital and queue the whole day. With those programs, we are screening TB, well, amongst other diseases. We are initiating treatment, and we are able to make follow-ups for refills. And that, for us, is a positive step, because it tells us that if we can keep them at work, keep them healthy, they don't lose, one, on their income. We also don't lose on our productivity. So business and the economy will continue to strive. And this partnership is not going to only end with those in the formal sector, because we talk of the underserved. The people in the informal sector are often ignored as people employed. And those are the people who have a very poor health-seeking behavior, because for them to leave their market stall, even for 2 hours, money for a day is lost. Because sometimes you sit there the whole day and you can only sell only 2 items. So we need to take care of those people. And we are happy that the intended businesses are also seeing the need to invest in allowing their employees to attend their health, to attend their the screening and treatment centers without much complaints. Yes, we continue. You know us as business, we always have targets and the like, but we are getting to a culture where we are saying part of your target is to make sure you have well employees. Then all your targets will be made timelessly. Awareness creation continues to remind our employees that it is not yet over with TB. We continue to explore ways to invest to end TB and save lives. Just this morning, we were able to send to all our companies a pamphlet that reminds them of TB. And where they are not accessible to emails, there are peer educators or workplace focal persons that read these messages. We have invested in Time for Health, Minister. Companies now, we have shifted from allowing our employees to receive medical messages during lunch hour. There is a mandatory 45 minutes at least a month that is dedicated to health. And each month they know, like for this month, they know the key topic is TB. Even when you can't give the 45 minutes at a go, we say just pick one thing for 15 minutes. They are trained to do that because it is important to continually remind them that we are here for business, and for business to strive, we need healthy workers. Thank you very much.
Thank you very much from Business Eswatini. I was so happy to hear that 45 minutes a week is now given to healthcare issues. Let's give her another round of applause. We are now moving on to legislators now. We have heard from Business Eswatini, but we haven't heard much about legislators as yet. We have a TB caucus. We have our MPs who are present here. Lebafaka Katsi, Sinyane Mvanengosi, Lapinze Balito again, chairman of TB caucus in Parliament, who's Honorable Markford Sbanze. Before he comes up though, I'm still Director of Health, Honorable Minister. I would like to remind people to adjust their masks so that we are indoors here. Let us all make sure that both our noses and the mouths are covered. It's meant to be 2 hours. We will be finishing shortly, but let us make sure that we want to eliminate, we want to fight this COVID. Having said that, may I please give the floor to our Honorable Markford Sbanze to give us his remarks.
Thank you very much. Siyabonga kakhulu, Program Director. Honorable Minister of Health, Senator Mage Lizinkosi. Once again, thank you for your support of the TP caucus. Honorable TP caucus members present here and my members a portfolio committee aga health siyalibona lizinyane bekakhona na chairman umhlonishwa Small Joe. Here Excellency the USA ambassador noma ke lommelele business Eswatini simbonile lommelele make Thobile Dlamini under sec waka health babe Phungwaye. When these two gentlemen were performing, ngitibutile nje babe Phungwaye ukuthi how do you feel? Because in 2005 you were part of the revolution that gave birth to Boslwane. Nabokok, I'm shocked because they still look as young as 2005. Masihamba all over the country. Sihamba ne concept called Pom Pom. Ngitsangubonge nje babe, thank you very much. Ngibonge Pepfla, ngimukele health care workers. Ngiphinze futhi ngibonge MSF, ngimhonorishe kuba khona kanye na World Health Organization kanye na Baylor umhlandi wendlunkulu. The Parliament TP caucus is grateful to be part of this World TP Day. This would not have happened, in fact, 5 years ago, or if I may put it correctly, ngasho ukuthi the 10th Parliament was not so fortunate to have had a TP caucus. So we're the fortunate one, and sithi asikubonge kakhulu lokho because we were lagging behind as a country, as a lot of countries were having their TP caucuses, committees. Sithi asibonge kakhulu once again to the health minister who was able to make sure that we launch this in April 2019. There have been so many advantages, so many wins, so many losses, so many gains. Maulalela labolkhele lababili labapresentile la. If I may compete with the program director ngekusho mhlawumbe emanang bengathi we are turning a big ship, and it's not easy to turn a big ship within a twinkle of an eye. Naga presenter Lukhele the first create that feeling it's icona la siyakhona but nje kunetigwaqana letisibambako. Then naga qhamuka Lukhele the second creator kokuthi it's been 100 years sika TB, and there have been so many successes in other diseases, including the one lesithandza kuba nayo noma lesinayo langangisita silwana ukuthi i-epidemic noma i-pandemic, i-COVID. So ke umbuzo loba mkhulu ukuthi are we turning this big ship? When you look at the gains, or when you look from a half full, without no, we are turning it. But when you try to be half empty, it's still tough. And again, naga presenter Bernard, I was so impressed. In fact, I realized ukuthi we need such engagements, because had I not been part of this meeting, tsine nje nelizinyane umntwana enkosi Phumelelo sesi better than lebe bangekho, than labangekho la. Bavame kusho bafundisi ukuthi you will always be better than Maufik. So there is so much information that in the end asiyitholi. But you see, portfolio committee aka TB, I think one of our successes was not just being a part of World Health Organization and other partners, including TB program. Maisifundisa about all these things, but lokuthi si participate. So we are so impressed ukuthi at least sikhonile ukuthi sibe part of it. We strongly recommended active multi-sectoral cooperation towards the TB response in the country. And this is what I'm talking about, that we were not just participating, but we contributed tremendously. And sifikile in this committee, we've been able, or I've been able to travel extensively and engage with other partners lebakhona la until the lockdown of 2020. Then everything was changed. And we're also pleased to note that the TB program is working towards full implementation of the multi-sector accountability framework, so that TB is not only a health issue, but cuts across all sectors for obvious reason. And that is critical and pertinent. I think that this is one of the best highlights lapha ehovisini laba bethemba. Loko kuthi bayikhiphe le TB from being a health issue. I'm happy the business sector is here. Kokuthi ba demonstrate lokuthi it affects all sectors of life. Program Director, Honorable Minister, despite the successes, it is worth mentioning, or maybe just one of the successes that we got was to be invited. Unfortunately, I was the only one, and even today I'm not sure what happened, but it means I was able to impress certain people. Utawukhumbula program director besinaye eZambia, whereby TB Caucus Eswatini was given participatory observer status in a meeting of health ministers as SADC in East Africa. So it was one of our highlights. And as I've already said, it's not all successes. There have been so many. We have had more than a fair share of unpleasant memories. The challenges includes obvious COVID-19 pandemic, which had devastating consequences to TB in more ways than one. There has also been lack of funding to implement some of the activities we had planned, such as visiting communities to educate them, hosting a series of workshops for MPs, attending TB conferences, and meeting with other TB parliament caucuses in Africa, in SADC, and the world. Program Director, Honorable Minister, we have an obligation to fulfill. In September 2019, during the first United Nations General Assembly high-level meeting on TB, heads of state, including Eswatini, pledged to provide leadership and work together to accelerate national and global action and investment to end TB by 2030. As the TB caucus, we are closely monitoring to ensure achievement of this commitment in this country. And as we commemorate the World TB Day under the theme, Invest to End TB, Save Lives, we are making a call to the government to accelerate the Abuja Declaration by allocating 15% of the national budget to health and prioritizing TB. I think if you can look at our budget, maybe necessitated by COVID, you can agree with me that the country was able in the past 2 years to live up to the promise of the Abuja Declaration. In conclusion, the TB caucus fully commits itself in the vigorous fight against TB and ensuring continuous checks and balances regarding TB. Ngalawo magama lamafisha sithi asibonge kakhulu Minister lithuba losinikete lona as a TB caucus, like I've already alluded, the 10th Parliament was not as lucky as us. And can I thank your partners who are here and sitting next to you, I was able to exchange numbers because I believe in networking. Ngalawo magama lamafisha sithi siyabonga kakhulu. Thank you.
Thank you very much. From our parliament, from our legislators, now we know where we are standing. Now we can see how the support we're even getting from the legislators. That is why that graph I was talking about earlier, which Dr. MSF also showed clearly, we have managed to achieve that because of all this work. Now, can we get the real example of the people who have survived TB? I've got two speakers who will please come forward. Pindile Obupindin. Please come up, sir. We will be followed by Mpendulo, just briefly to tell us how it feels to be a TB survivor. Abu Tsatsano. Yeah.
The Honorable Minister, members of the Parliament, health workers, TB survivors, ladies and gentlemen, I greet you all. Standing before you is Pindile Shonge. I started my TB treatment on the 27 May 2019 up to 2020. I was taking both injection and tablets. 8 months for the injection every day and 2 years for the tablets. I had some challenges toward the treatment as it was a long journey to go. But thanks to the Minister of Health, the healthy workers, my family, my church, Hope Restoration Church, I would love to thank the government, healthy workers, my family for being in my journey with my TB treatment. I can also encourage other Swazi who are still doubting to go to the clinic for testing TB. TB is curable. Thank you all.
Itsatsele lithuba nalomhla ekuseni ngivusele sive seMaswati. Libito lami ngimpendulo ngwakakhumbane Sibonga. Ngike ngalashelwa TB since iqala 2019 up to 2021. TB ngingathanda ukukhuthata kakhulu esiveni seMaswati kubantu labasha kubantu labadzala ukuthi TB sifo lesilaphekako. Futhi nasonayo kubita kwamukela uthathe emaphilisi akho ngendlela lefanele. TB mawuyiphatha kahle ngekwendlela yekwelulekwa bodokotela nabonesi nayo ikuphatha kahle. Kepha wayiphatha kabi uhle ungawanathi emaphilisi akho ngendlela lefanele ikuphatha kabi. Kuyaye kube netikhathi ukhande ukuthi TB ithatha isikhathi lesidze kulapheka. Then na uhle ungawanathi lamaphilisi ikubeka engotini yokuthi TB yakho ingagcine igwama nalesikhathi sekwelasha kwakho sichubeke sibe ngilesitse. Ngitsanza ukuthi bongela kakhulu department yaka MSF letimisele kakhulu while isana kwa impilo yami. Ngike ngafacana nema challenges lamakhulu empilweni yami. Ngitibuta ukuthi ngidawuthatha ini ke manje nasekwendeka kanje. Kephana lengibonga kakhulu ukuthi basisekele kakhulu. Ngide ukuthatha esiveni sakithi singeMaswati ukuthi asibathanze sibanakekele bantu nabo. TB yindzaba yethu sonke. Asiqhubekeni sitinake nathi sibanakekele nabo. Itawendlula siqhubeke nempilo nginake kafishane bengifundza sikolo kwangibida ukuthi ngidrop out bese sitobhala ngahlala ngasesibhedlela ngalashwa ngakwemukela ngathi eish sekwendekile ngeke ngisakhona kuya eklasini because nangichubeka ngifoster kuya eklasini ngithatha labanye bafundzi ngibabeka engodini kepha ngemsa waNkulunkulu ngibuyele eklasini ngiyafundza impilo iyachubeka ngibonga kakhulu.
Thank you very much. One always often wonders what TB has killed so many people, have taken so many lives. But at the same time, it is curable. And we can see examples. These two people who are just talking now are examples of people who have gone through TB. I know there are many others, but at least they gave us a glimpse of the hope that the work that we are doing is actually there. Ladies and gentlemen, we're going to be switching off now again to hearing remarks from the representative of the United States of America, and Her Excellency will be represented by the head of CDC, that is Dr. Michelle Edler, who will give us the note. And then we'll recall, ladies and gentlemen, that the United States government, amongst others, has contributed a lot to the fight of more than just TB. More than just TB, ladies and gentlemen. Sometimes I always wonder, say, if we were not getting all this assistance, where would we be? Ladies and gentlemen, I present to you Dr. Michelle Edler to deliver her note.
Good morning, Honorable Minister of Health, Parliamentary TB Caucus Chairperson, Honorable Macford Sebenzi, Honorable Members of Parliament, members of UN agencies, Ministry of Health partners, representatives from the NGO community, representatives from the business community, distinguished guests, ladies and gentlemen, all protocol observed. It is my honor to be here today representing the U.S. Ambassador, Jean Maloney, to reaffirm our commitment as U.S. government to eliminating tuberculosis and saving lives in Eswatini and around the world, and to raise awareness about the disease. We all know that TB is both treatable and preventable, as has been reinforced here today. But nevertheless, it remains one of the world's deadliest infectious diseases. Indeed, more than 1.5 million people lost their lives to this disease in 2020, including over 200 just here in Eswatini. The theme for World AIDS Day, again to reiterate this year, is Invest to End TB, Save Lives. In 2020, TB cases and the global number of TB deaths increased, and Eswatini hasn't been spared. To safeguard lives, we need to regain everything that has been reversed by COVID-19 and make the necessary investments for the cause. Time is running out for the world to make good on our TB commitments. As has been noted, in 2018, world leaders committed to diagnosing and treating 40 million people by 2022, including 3.5 million children, and they committed to reaching 30 million with TB preventive therapy, and to mobilizing financial resources to invest in research for better science, better tools, and better delivery. We definitely have the means to break the cycle of transmission of TB disease by identifying infected people and using TB preventive therapy to treat latent TB. So the time to act is now. The Eswatini 2020 TB program report showed that only 2,102 patients in Eswatini were started on TB treatment in 2020. This represents an estimated 58% of the people who had TB in 2020. So it is clear that we must find and treat more people with TB if we are going to meet that critical 2022 global health deadline. We can and we must do better. The US government has invested over $676 million through PEPFAR in the public health sector in Eswatini since 2004. These investments have helped build and thank you. These investments have helped build an infrastructure that not only provides the tools for comprehensive AIDS relief, but also to combat other infectious diseases such as COVID and TB. And let us not forget that TB control is a critical element of the fight against HIV. Just as we were progressing in the right direction, COVID-19 threw us a very big challenge. PEPFAR-supported programs in Eswatini reported an 8% decline in new cases of TB in 2021 compared to 2020, which unfortunately is not because COVID made TB disappear, but because attention shifted away from TB diagnosis. As my colleague from MSF highlighted, even though the COVID-19 pandemic interrupted some of our efforts toward conquering TB, the national program has remained resilient, adapting TB screening, diagnostic and treatment interventions to maintain availability and accessibility at facility and community levels. As an example, in 2021, despite the COVID pandemic, PEPFAR-supported programs initiated over 38,000 people on TB preventive therapy, people living with HIV on TB preventive therapy in Eswatini. Again, this year's theme is Invest to End TB and Save Lives. The US government, through PEPFAR, continues to support the government of the Kingdom of Eswatini to mitigate the impact of COVID-19 and put the country back on track for TB epidemic control. In addition, we're pleased to be providing financial and technical support to the Baylor Catalytic TB Gaps Research Initiative through the US Centers for Disease Control to identify more cost-effective screening and diagnostic algorithms and optimal TB preventive therapy regimens with a particular focus on children. Controlling and eradicating TB requires strong partnerships. And we are grateful for the steadfast support of our implementing partners, many of whom are in the room, stakeholders such as yourselves in this fight. Here in Eswatini, our PEPFAR team, comprised of personnel from the US Centers for Disease Control, USAID, Peace Corps, the State Department, and the US Department of Defense, engage with the national, regional, and community partners to support coordinated TB interventions. At the ground level, we are improving facilities and infrastructure to prevent and treat TB. And at the national level, PEPFAR is committed to supporting and strengthening the National TB Control Program's capacity for planning, coordinating, and monitoring activities. The US government stands with the government of Eswatini and the Ministry of Health as they work toward attaining global commitments and ending TB for good in this country. So although Ambassador Maloney was not able to attend in person today and sends her sincere apologies for not being available in person, she did not want to miss this opportunity to say that we are proud to invest in the future of Emaswati by addressing health threats such as HIV, TB, and COVID-19. And by the same token, we must also work together to help Eswatini heal from the recent civil unrest. We look to the government of the Kingdom of Eswatini to communicate details on the upcoming national dialogue and develop a process that will promote healing for the entire country. This is a moment of historic importance in Eswatini. So taken together, these actions are making a difference in people's lives. And we commend all of you and everyone who has committed themselves in ways both large and small to the fight against TB. Our successes, however, do not mean that there are no challenges left to overcome. If anything, Our accomplishments give us the strength and inspiration to continue the fight. We are still witnessing high mortality rates, up to 11% among TB patients. And we cannot truly achieve success in TB or COVID-19 without vigilant action, advocacy, and surveillance among healthcare providers. As such, I would like to offer an appeal to everyone here today. In addition to your advocacy and commitment to TB, please take your COVID-19 jab if you haven't already, and encourage people around you to do the same. It's free, it's available right now, and we really encourage everyone to please be part of the solution to help protect yourselves, your loved ones, and communities from the worst effects of this disease. We have the means to end TB epidemic in our lifetime, and to do so, we must redouble our efforts to fight and treat TB disease. The investments in people, infrastructure, and resources made today, especially through PEPFAR and our partners, are vital to reinforcing these efforts. We need to double down on our efforts to scale up TPT and prevent TB. According to the latest WHO report, 80% of TB financing is donor supported, with 7% unfunded. And we therefore appreciate the advocacy of the Parliamentary TB Caucus and support the call to further prioritize TB within the national budget. This is the time to invest to end TB and save lives. Siyabonga.
Thank you very much from our CDC head, who's representing Her Excellency, the US Ambassador. You had for yourselves the investment that has been made by the US government on Maswati to help us that. Now we will move on to the remarks from the UN. And I understand the UN Acting Residence Coordinator is going to be represented by the RCO team leader, Mr. Ben Ofusu Korateng. If I mispronounced, my apologies. Thank you, sir.
Thank you, Program Director. As you said, I think I have the longest name in, in the whole of today's session. Again, my name is Benjamin Ofosu Koranting, and I'm standing in for Amina Mohammed, who just this morning had a health emergency. And so I'm standing in and reading her notes. Honorable Minister of Health, Honorable Member of Parliament, Your Excellency the US Ambassador, the Principal Secretary of Ministry of Health, Ministry of Health officials gathered here, Business Eswatini CEO, MSF, UN colleagues who are here, the media, distinguished ladies and gentlemen, good morning to you all. On behalf of the United Nations family in the Kingdom of Eswatini, it gives me great pleasure to be among you this morning as we commemorate this important day, the World TB Day. This year's theme, Invest to End TB, Save Lives, emphasizes the urgent need to invest the resources needed to revamp up the fight against TB and realize commitments to end TB by global leaders. The commemoration of this day remains important in raising public awareness and understanding about one of the world's deadliest infectious diseases, effects, as well as its devastating health, social, and economic impacts. I would like to applaud His Majesty's government for the tremendous strides made over the years in the fight against TB, amidst the high prevalence of HIV infection, the rise in TB-resistant forms of TB, and the high burden of non-communicable diseases, as well as the ongoing COVID-19 pandemic. Indeed, the Kingdom declared TB as an emergency in March 2011, and thus intensified efforts towards fighting the disease, which has been evident in the strong, high political commitment, as well as the multi-sectoral and whole-of-government approaches to prevent and control TB. Through the implementation of different strategies, new TB infections decreased by 80% from more than 11,000 cases in 2011 to about 2,000 cases in 2020. The TB treatment success rate is at 86%, just 4% less than the global target of 90%, which the country is trying to achieve. This means many TB patients are cured, including those with TB and drug resistance, and lives are being saved. Eswatini has seen an increase in the uptake of preventive measures such as TB preventive therapy, the deployment of community health workers and TB case finders who conduct door-to-door community engagement activities has contributed towards attaining these commendable achievements. Eswatini is now counted among countries that have made significant progress in reducing new TB cases and deaths, and is among the early adopters of the WHO guidelines and policies on TB prevention and control. Despite these achievements, there is still the need to accelerate efforts towards finding the missing cases, scale up access to TB prevention, diagnosis, and treatment services in the country. At the UN high-level meeting on TB in 2018, world leaders agreed to mobilize 13 billion per year to finance TB prevention and treatment by 2022, which is this year, and promised another 2 billion per year for TB research in the face of growing concerns around drug-resistant TB. However, funding for TB prevention, diagnosis, and treatment services continues to fall short of estimated global needs and the United Nations global targets. In Africa, governments contribute only 22% of resources required to deliver adequate TB services, with 44% going unfunded, seriously impeding efforts to reduce the TB burden on our continent. Increased funding from domestic sources and international donors is thus urgently needed if we are to counteract a reversal of the significant gains made against TB in the past decades. At the current rate of progress, the UN Sustainable Development Goal target of ending TB by 2030 may not be achieved. The coronavirus pandemic has also compounded the challenge. In 2021, the world saw an increase in the number of global TB deaths for the first time in over a decade. Reduced access to TB diagnosis and treatment in the face of COVID-19 pandemic has also been a contributing factor. Clearly, increased investments can be a game changer and alleviate the preventable suffering and death of our people, especially on the continent and including Eswatini. In her message for today, the WHO Regional Director for Africa, Dr. Matshidiso Moeti, has called on governments to mobilize additional domestic financial support for TB control, including contributions from the Global Fund, which last month launched its 18 billion 17th replenishment campaign in a bid to counter the catastrophic impact of COVID-19 on the fight against TB. It is in this context that we urge all stakeholders to advocate for increased investments and to ensure that TB services are integrated more and more into the primary health care response. We appeal to donors, to the private sector, to civil society, to academia, and indeed to the UN in general, to pay increased attention to urgently boosting investments in the fight against TB and in the TB research in order to accelerate technological breakthroughs and the uptake of innovations towards ending TB by 2030. Thank you so much.
It's so delightful to hear all those words from the UN body. Now, it is time for the multi-sector collaboration and coordination from our very own. I must tell you, Honorable Minister, he used to report to me, and I sent him to school, actually. He went to do a master's there, okay? I signed the papers. But he came back, is now a boss. So I want to hear from him now, from the multi-sectorial collaboration approach of you, our Undersecretary in the Ministry of Public Service, umqashi, urepresent umqashi. Siqashwe nguye sonke lo sila. Babe Richard Pungwayo.
Still the boss. Wow. It's good to be home. Health is my home. I didn't take offense when Umhlonishwa Makford addressed me as Undersecretary for Ministry of Health, not Public Service, because I'm sure that's the route now, Minister. I'm getting there. Honorable Minister Imbunga, Magdizi, Nkosi, and the representatives of the US ambassador in our midst, a parliamentary caucus, lekhona kithi, mkhathisini wethu, the business community, development partners, and distinguished colleagues. Kunenkinga at times where you prepare something, and then when you get to the arena, you change things and start listening to your heart of what was obtaining on the ground and what is happening here. I've asked myself in terms of the issue of the Invest to End TB and Save Lives, so many questions about Ministry of Health because they've always been in my heart. I've been the poet that has moved around, and I've got a good picture of how health looks like. And one of the things that has troubled my mind is how far is this investment going? We might celebrate Minister here. Someone would call it on borrowed ropes because we're supported by partners. Have we made investment ourselves in the health sector? At times when you look at the establishment register, it hasn't changed much from what it used to be. Part of the investments must speak to re-engineering some of our functions and job descriptions, even grades and remuneration. The discussion has to carry on. I know there must be probably fatigue from some colleagues who've made attempts in the past, but it doesn't help to be fatigued.
still the discussion has to move on. Our partners have helped us in making sure that we have capacity, but half the time the capacity goes away by the time donor funding ends. And some of the functions that are there on the ground are stopped, and that pains ourselves as a country. So these are some of the things that I asked myself to say, what am I going to be saying there? Since things haven't changed much, and we still need to invest in that kind of thinking. So what's obtaining on the ground is what I've said now, and one is tempted to even say, Minister, when you look at the investment itself, it shouldn't just be knowledge only. It should focus on so many areas, which sometimes even speaks to the issue of accountabilities for people that we actually gather in the multi-sectoral approach, because that's the essence of the multi-sectorality. We have accountabilities. One of the things maybe one would applaud the ministry for is the wisdom and professionalism displayed by the ministry in always seeking for multi-sectoral and collaboration models when dealing with epidemics requiring such, and that is humbling and commendable. Most disciplines are always protective of their domains, leaving no room for assistance, even when in dire need for support. Such committees, in general, Swabona, Minister of Parliamentary Caucus, and others, need the support of the ministry. And for effectiveness, one should actually make this comment that where we have such multi-sectoral disciplines assisting the ministry itself, it must speak to the issue of the ministry defining the functions and roles of such committees. Because at times we create these committees and then we leave them to operate on their own, and they don't give us much as expected. Bese abastale minister. I can make reference to HIV and AIDS. I remember I was in a meeting where it was a number of committees, multi-sectoral committees had been formed, but there were no guidelines and roles and functions of those committees, causing confusion in the first place. So you would hear Chim Shak, Pish Shak, what was Shak? There was a lot of shacks in the room. And you ask yourself, how are these things coordinated? When we form these things, we form them in good heart because we always know the outcome that we need. But we don't map the step-to-step processes towards the outcomes that we need. So as we form these things, we must actually be able to manage their roles and functions and manage follow-ups and evaluation of such so that we can actually get the best out of them. I'm even tempted again as I reflect back. Like I said, I might even ignore some of the things I had written here. When I look around the room, I'm reminded of whether we need to do something about the excellence that is in the room, Minister, in terms of the health workers that we have. The people who have championed departments, really championed departments. But when you look at the grade and pay, your heart sinks. I do not want to depress people. That's why I'm saying I'm just reflecting back, and I'm remembering one of the stalwarts this ministry has ever had in the malaria program manager, who was respected elsewhere, everywhere in fact, but not in country, in terms of what I'm speaking about. As I sit here again, I'm seeing the program manager, TB, and I'm wondering if anything has changed, because these are some of the things that we need to look at. They have championed this space. Can you give me a round of applause? Again, I'm reminded, I'm seeing a lot of faces here that I've worked with. There was a time when there was the health sector response plan. We all used to dress up smartly and present from one corner of this country to another corner, building capacity for the response, but had nothing. All we had was our confidence only. People look at us and say, no, these are big people. until they look at the pay and say, there's nothing here. So see some of the things that pains me, Minister, whether I'm saying the discussion should carry on. We should never be fatigued by this, because that's injustice. It needs to be, it needs to be addressed. I know the Deputy Director is aware of that, the fellows here that I've worked with, where we just showed confidence from nothing. So many of you did that. And I applaud the ministry for doing that, regardless of the problems that are there. You are the best. I might sound like I'm paving my way back to the ministry, Dr. Director. But it is one of those things that, touch you as a person when you see the development and changes that are being made in other ministries, and you ask yourself what happens to ours, which is doing so much work. I'll end up by going back just in a second to reflect back on the gains that we've had on the multi-sectoral approach. These do assist, these work, but like I've said earlier on, only if they have drawn terms of reference and roles and responsibilities to avoid conflicts, because you cannot garner support on your own. Some people need to do that for yourself. So I'm hoping the Parliamentary Caucus on TB is one of those that are going to stand up, not for Mlangeni, but for the program itself. You must look beyond the person, but look at the program itself and how we could strengthen it for such work that has happened here. This would actually give us more benefit from the multi-sectoral approach which the Parliamentary Caucus is bringing up. And the other partners that are here, as we all join together, multi-sectorality doesn't just come in terms of the outside people from health. It only even speaks to departments within health itself to have one common goal and stop the silo mentality of this is mine, and I'm not accepting any assistance. So these are some of the things that will help us produce the best out of the staff that we have. We are yet to see the best of the staff at Ministry of Health. And as the Ministry of Public Service ourselves, we are encouraged by the work that has been done in terms of the health response itself. And I do request the authorities of the ministry to actually carry on with the engagement and do pledge my support. I've not been told to come and say that, but I'm just saying where you need support, one would actually avail itself so that at least things change for the better. I was expecting hands for that. That should mark the end of my speech. Thank you very much. Ladies and gentlemen, I think the moment we've been waiting for, now the address from the Honorable Minister. So I'm now switching on my jacket and I'm putting on the jacket here, Dr. Zwane. But we will recall he is a small figure, so it will be difficult for that jacket to fit for me. May we put our hands together as we about to hear the keynote address from the Honorable Minister, Senator Liz Nkosi.
Early so you wouldn't make lengthy introductions. Chairperson, Honorable Chairperson and members of the Parliamentary TB Caucus, representative of the US Ambassador, Head of CDC, Head of MSF, Executive Director Baylor, representative of the UN family here, senior health officials that are here, business sector representatives, That way around, yeah, okay. Members of the media, thank you very much. Distinguished ladies and gentlemen, a good day. It is indeed an honor for me and a great pleasure to be here today to join you and join the international and global community in the commemoration of the World TB Day under the theme Invest to End TB, Save Lives. We are here, I'm sure that you have heard the story of the country being told of what we are doing, what we've been successful at, what we are hoping for from our program manager, from our partners, and you've heard a lot of numbers today of where we are at, where we've been, and how we have dropped. So my remarks today are going to be reiterating some of those sentiments. Reiterating because we do work together, and therefore we're telling the same story, but also reiterating because we do work differently. As you will have heard, we are coming from different perspectives, but for the same end. Reiterating to emphasize some of the things that we need to remember. TB remains one of the public health concerns in the country. We've made tremendous interventions in the past to curb the scourge. The interventions include robust awareness about TB, infection prevention and control, introduction of rapid diagnostic tests, and uninterrupted supply of drugs, integration of TB and HIV and NCDs, patient follow-up, decentralization of TB and HIV services to the community, and active case finding. Eswatini government has taken a leadership role to provide quality TB services and also ensured a conducive environment to attract partners to support the response. In the past 10 years, the country has seen consistent decline in notified cases from 7,000 cases to 2,045 cases. This has seen an incident drop from 12,000 cases per 100,000 patients to 319, which you've heard earlier, to 319 per 100,000. Amongst the cases that are being notified, the health system has managed to achieve a treatment success rate. We're talking about people who are cured and have completed their treatment, of 81% in 2021. This is 9% short of the global target of 90%. Unfortunately, the death rate has increased from 8% in 2019 to 11% in 2021. Even though the Ministry of Health, through the National TB Program, has made significant progress towards TB control in Eswatini, a lot still needs to be done. Improvement in treatment success has been observed over the years, from 78% in 2015 to 89% in 2019 for drug-susceptible TB, falling 1% short of the WHO target of 90%. However, a reversal of 8% was noted in 2021. This drop was mainly caused by increased death rate among TB patients from 8% to 11%. The past 2 years of COVID pandemic saw deaths of those co-infected with TB and COVID. The program has set a target of less than 5% deaths due to TB. However, high death rates of above 10% still affect the final treatment outcomes. WHO talks about the pediatric cases should be between 10 and 12% of all cases notified. Pediatric cases, TB cases, have been ranging between 5 and 6% in recent years. The nature of the disease in children, as you have heard, makes it difficult to diagnose, as well as the screening challenges that still exist. However, the program is exploring another specimen that is very easy to obtain for TB in children, such as the stools, as a first entry of detection. There are many other tools that are being explored. The 2021 annual TB data shows that a TB prevalence of 58% among men and 42% among women, with the most affected age group being the group between ages of 25 to 50 years. We all call upon men across the nation to take action and be tested and treated for TB to stop the spread of the disease. As we commemorate TB Day today, it provides us with an opportunity to celebrate our achievements, which include a patient-friendly treatment regime, shorter TB preventive treatment, which now is taken only once a week for 3 months. The launch of TB sequencing, which will strengthen drug-resistant TB diagnosis to ensure optimum treatment outcomes. The integration of TB and COVID-19 services to scale up diagnosis and linkages to early treatment. Lastly, Eswatini has started the 3rd phase of the TB in mining sector project. We call it TIMS 3, in 3 regions in the country, Shiselweni, Manzini, and Lubombo, with the aim to reduce TB burden among miners, ex-miners, their families, and the communities. As a ministry, we are grateful to all partners for the support over the years that have enabled us to mark these significant achievements, and we look forward to our continued collaboration to end TB and save lives by 2030. Today is a reminder to us all that we must take action to invest to end TB and save lives. I therefore urge everyone in the country to take good care of relatives who are being treated for TB, and I plead with TB patients to commit to adhering to treatment for optimum outcomes. Just today, we've seen 2 young people who have successfully completed what sounded like a very, very difficult time. You know, when you talk of 2 years of treatment and staying on it consistently as a young, active person, we need to applaud that and encourage other, thank you, and encourage other TB patients to just adhere to treatment. TB is curable. And to the business community, thank you for walking the journey with us. We continue to plead, we do have a funding gap, so we continue to plead for assistance in that regard. We cannot do this alone. We need to move together to free the country of TB. So we will welcome your pledges. As I conclude, thank you all for joining us in the commemoration of this very important day. There is an urgent need to invest resources and ramp up our fight against TB to achieve the national and global commitments to end TB. This is especially critical in the context of COVID-19 pandemic that has put end TB progress at risk and to ensure equitable access to prevention and care in line with WHO drive towards achieving universal health coverage to which we subscribe as a country. And before I end my remarks, I want to thank you all for wearing masks here, for being socially distanced, and I want to thank the nation for continuing to wear masks. I know I have been asked so many times, when are we getting rid of these masks? South Africa has just announced that you can go through the border freely if you're vaccinated. So I encourage all of us to just vaccinate to free ourselves from this mask. We're still under 30% coverage. We need to get to 70%. But vaccinate. The vaccines are free, they're effective, and they will enable all of us to come back to as normal a life as is possible. And to answer your question, when are we dropping the mask? We will let you know, but please vaccinate. It will be soon. We need to align with our neighbors. We need to align with the region, but we also need to make sure that as we do that, our entry points have all the necessary tools and instruments to make sure that we can check and see that people have the correct certificates. The announcement came, we're not quite ready, and we are working on those things, so please vaccinate. Vaccinate. Thank you.
in that last part, because every other phone call I'm getting, and the social media, left, right, and center, everybody wants to talk about that. At one point, I had to remind people that President Ramaphosa is the president of the Republic of South Africa. This is the kingdom of Eswatini. We shouldn't forget that. But of course, thank you very much, Honorable Minister, for addressing that critical and pertinent issue. It is not the masks that are actually the issue here. It is the COVID. We have seen what COVID has done to us. If you've not been touched by COVID, Imbela, you're lucky, one way or the other. What we saw happening, Stegi, TLC, people, let us not forget so easily. We don't know what is going to happen. Ladies and gentlemen, we have come to the end. I know that I skipped Sloane at one point in time. The Honourable Minister has to go to Parliament. And these are the things which have made, has given us this investment in TB. It has given us the results which you are seeing, the Parliament. So the Honourable Minister has to leave. Can we give her a round of applause? May my deputies please escort the Minister. She can't come alone. You know, in other countries, when a minister comes, everybody stands. We also do subscribe to that. It's just that she sneaked in because she didn't want us to do all that. Ladies and gentlemen, we are coming to an end, but I think there's enough room to listen to Sloane now with their messages before we conclude and end everything. Sloane, usekhona Sloane?
Suka nje kuloko silwana kwalabafundzile lokho.
Ladies and gentlemen, all protocol observed.
Hawu I think TV senami yathi washo ngeva mnandi.
Bengathi. Mnanzi ke kumala. Akuyamo, awuyami, uyema nje, yes. Bese uyakhuluma.
Silwane kusuke sekulo
Posture.
lo semagunyeni.
Chest out gogo ngifundisa that info that. Chest out. Chest out. Cala.
Uthi ngaba khona kodwa silwane.
Ngofuna usuke ke lapho phela.
Uthixo.
Ngofuna usuke lapho.
Kuyinkinga lokho silwane.
Akudlalwa lapho.
Kuyinkinga lokho.
Kulungela thina mina ngeke ngaba ngumfundisi ke gogo uyangadi ke wena.
Silwane into oqale mangafuna uqala de usukuteni umuntu lokwadi kodwa udane. Uyabona? Ngizabe mfundisi nje msuyifaka la.
Ngishumayele kakhulu mina yethi kulamalanga basengimisile khola basakuphenya but nakuhambe kahle bangakathola utho ndawuchubeka ngishumayele. Nangabe khona lo ngakuthembi lokho futhi ngingasonzela kuwe. Nikuside.
My God.
Ngoba thina sithunyiwe ngeligcobo lasekhaya ukuthi sisite abantu. Gogo. Lana basicela ukuthi asisonzele sinagogo sitokhona kubusisa kudla. Ngiloko nje lesikutelela nyalo. Sitothandaza ukuthi salo singakhona ke ekudleni. Kude lokunye lokho
badle abantu.
Badle abantu bajabule. Badle abantu bajabule.
Nidle nikhululeke abantu abami ngibhadele. Nidle nje nikhululeke.
Ni covered. Timbasha manike sesivena ukuthi kujama nje. Oh sorry. Kwethu ukutothanazela kudla. Ngalo sekhwala badlako out naloko ukuthandazela kudla.
Yesilwane.
Out. Siyacela ke ukuthi masiya lapha.
Stofundisa.
Masiya lapha. Ungenti lento yakho yekubibilela nje.
Umuntu aqhamuka sagenza bolethisi ngetithupha la platini phakela kahle nje.
Phakele ngathi uthi khoze ungabuyela
Phakela
kude
ngathi
kudinkinga.
awuhlanzi.
Uthi nje yakabe sibuhlale phasulu.
Ngibatiko labalale ngeke ngibakhombe nyalo yeke lani lokho bese seniyabibiyela lapha nithela isosi khona la itulu konke kula itulu. Nane ice cream la.
Lapha nje phakela kahle. Mawungasusa utaphinze ubuyela.
Utaphinze ubuyela asikhutana.
Sisitele ukutofundzisa lokho. Ngilonje umsebenzi wethu wekuthi siniside. Gogo.
Silwane.
Ngekulunga thina ukuthi salo siphazamisa isikhathi sekudla nyalo.
Abantu abasukume bayodla
Nyalo
Silwane.
isikhathi sekudla
But
nyalo.
asinase baphakele bonke.
Angithi ngizama lokuphela yabo nje babuka make lapha makubuke le thina singala. Yabo le ingcondo yakhe yonke. Ile ngithini vele.
But athi bangaphakela ke Silwane bangahlala phansi bese siyakhuluma.
Labanye futhi vele basuke ekhaya basukela le yangcikithi.
Lengcikithi.
So lokho yakhulunywa nje lana akeva. Mawungaje
Uyabuza nje.
uveni bukela phela. Uthi nje uveni tawulalela. Lo muntu utengale ngcondo vekutodla yena la. Akekho nje la. Uyabluza nje.
Hayi ungabuki phansi siyadengcela.
Khululeka.
Siyadengcela. Hawu.
Ngidafika nje ngikunika umbhobho mina uthi uveni tawulalela wena. Tawusela tawulalela wena. Ngoba uyambona uflotele utodla ukuthi yathi lana lo muntu akekho la. Hayi ungaminyi. Ngiyenza mina. Ungaminyi. Ngiyadengcela.
Yesilwane.
Lokuminya kusita kuphi nje ngoba
ngeke Silwane ngeke.
gogo ungamsukela umflo mbona ukuthi vela kati lutho nkosi
Silwane
yami.
ngeke.
Mina nafike nginika umbhobho ngithi uveni.
Uveni solokuqalile.
Utawulalela wena. Ngoba phela nitele kutodla la kuyakhulunywa phansi zabathi imcoka nine nani. Yey sesifikile.
Siwena mathi uyabhala.
Umsa nje kubhala buka lana nobhala ema order. Oh sisi uyathengisa impahla ngibona jeans, duvet. Wena usebusinessini sikhuluma le tempilo wena usebusinessini. Ngeke sikubuta ukuthi uveni because ku obvious awukeva lutho.
Wena ucabanga namaduvet.
Gogo buyela. Hey unesibindi baba shebe uzuyivulile. Phela kunana kwena uyabona lokho kuthiwa ku minimize. Nakuthi abantu futhi minimize awushinje kanti vele ubukela into le wrong uyabona.
Ukubukelelani lokho?
Uyibukelelani into le embi kwebantu nje. Phela
Thina semsebenzi lomkhulu wenu uyabukela.
noma sonesibinzi
Hayike.
Asikwestion enkulumo la sayiveta
Hayi
lapha.
sesidlala ngelisheke.
Gogo wenza njani nje? Wenza njani?
Silwane bengingafunzi ikhulumise lena manje.
Okay.
Ngingafuni manje Silwane manje. Sengaba ngosibathu ngoba bafuna kuyiva Silwane.
Gogo yekele.
Asiyekele nje singayithinzi.
Ngoba lo naba abantu balalele
ula nawo
ene wena ufike
umlomo nangiphasa isifonyo siyathi
umbhobho nangi uletha ku
umbhobho nangithi
utshela thina nje uthi uveni wena
pandemic and
uNkulunkulu wami
solugcinele eceleni hayi bathi uvile siyabonga kakhulu uveli
Base besaba kusukuma bayodla
khona amatafula lobonako nje singawudlala ngesikhathi vele labantu abekho ayini
Silwane,
abekho nje la labantu
Silwane
yemna yethu kude shule siloyifasako lapho sila yemna yethu kude mashule silowafasako wena vusa inhloko sifuna lentele kudla namhla kunisotha nifake elayinini
ngeke kubitwe abantu batofundziswa wena utele liphalishi
ngeke kubude mnethu ngicela uhambe usibambe elayini ukhona kudla yes
daza shaya siyeti
naw hamba udla ukukhululeka
nina lenikutshele ngilamaswiti solo niqobe amaswiti la
yebo sisi ngoba lamaswidi sonke besicushelwa nini le plastic lonke nilithole njani yini bakithi nini intellectual lamaswidi lana
asukumene siyodla
ngicela sithole nini singakudla lapha kwa ngifuna kusho masenidla
nasenidla